Hello, everyone. Thank you for joining today's Alliance for Health Policy briefing on understanding the future of COVID-related Medicare and Medicaid flexibilities. I'm Sarah Dash, President and CEO at the Alliance for Health Policy. For those who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the health policy community dedicated to advancing knowledge and understanding of health policy issues. Today, we will be discussing Medicare and Medicaid flexibilities that were put into place in concert with the public health emergency. There were hundreds of such changes that were truly unprecedented, covering public health, delivery system reform, coverage, and much, much more. Today, we are going to focus specifically on Medicare and Medicaid flexibilities that dealt with primarily delivery system reform as they apply to the future of person-centered care for people with complex care needs, older adults, and people with disabilities. So there will be a narrower scope to the conversation today. But before we get started, I want to briefly lay out the current lay of the land on the PHE declaration and the timing of it so that everyone has a little bit of context. We will not be debating in this conversation when the PHE declaration should end, but simply having a conversation about preparing for that potential eventual future. It is an active debate right now in policy circles. So just very briefly, the federal public health emergency declaration for COVID-19 was originally issued in January 2020. It's been extended 8 times since then. Each PHE declaration lasts for 90 days unless the administration chooses to end it early. The current public health emergency declaration is slated to end on April 16th, 2022, but most predictions expect that this will be extended for another 90 days into mid-July. The administration has committed to providing 60 days prior notice prior to ending the PHE. So the next date to watch, if the PHE is extended beyond April, would be a mid-May announcement. So again, that is at the federal level. And then at the state level, state emergency declarations allowed governors to issue mask mandates, stay-at-home orders, vaccination requirements, among other things. And as of March 2022, 20 states have COVID-19 related emergency declarations in place. Most will expire within the next 1 to 2 months unless governors choose to extend them. And at the beginning of the pandemic, all 50 states had emergency powers in place. So again, there are active conversations about the public health emergency declaration extension occurring at the federal and state levels with important implications. And the purpose of today's briefing is going to be to focus on the eventuality of when that does end, what happens with the multitude of Medicare and Medicaid flexibilities. So with that, our panel is going to be a forward look, and our expert panelists are going to help us explore what we know, what we don't know, and provide some considerations for how to assess these flexibilities moving forward. So with that, this event was organized by the Alliance for Health Policy. We were pleased to partner with Health Management Associates and Manat Health Strategies with generous support from the SCAN Foundation. Let me share a few quick housekeeping notes. You can join the conversation on Twitter using hashtag AllHealthLive. Join our community at All Health Policy as well as on Facebook and LinkedIn. Today's panel will have a Q&A section. We have 90 minutes today for our panel. Please do participate in the Q&A actively. Share your questions at any time during the broadcast, and you can chat with us if you have any technical issues. And now I am excited to introduce Dr. Sarita Mohanty, who is the President and Chief Executive Officer of the SCAN Foundation. Dr. Mohanty, hello, it's so good to see you. Dr. Mohanty is a practicing internal medicine physician with Kaiser Permanente. She previously served as Vice President of Care Coordination for Medicaid and vulnerable populations at Kaiser Permanente, as an Assistant Professor of Medicine at University of Southern California, Chief Medical Officer of COPE Health Solutions, a healthcare management consulting company, and Senior Medical Director at LA Care, the largest U.S. public health plan. So thanks for joining us, Dr. Mohanty, and I'll turn it over to you.
Thank you so much, Sarah. And I really want to thank the Alliance, HMA, and Manat teams, especially you, Sarah Dash, Jennifer Baduka, and Stephanie Anthony. And I really appreciate this opportunity to briefly reflect on this important topic. And because today's discussion, as Sarah mentioned, is focused on the temporary flexibilities of Medicare and Medicaid that were approved during the COVID-19 pandemic to really ensure people could maintain access to the care and services they needed. These flexibilities have really allowed states and local providers substantial benefits in how medical and long-term care can be organized, delivered, and paid for through Medicare and Medicaid. And these flexibilities have elevated new ways to deliver person-centered care to aging Americans, those living with complex care needs, and family caregivers beyond what was previously imagined. We recognize that policymakers, have to weigh many considerations as well as navigate some unknowns, which will take time to assess whether and how to make these flexibilities permanent. So we see tremendous value in using a person-centered, equity-oriented framework as a real focal point for considering the future of these flexibilities. There are changes in how Medicare and Medicaid pay for care that could better support older adults with complex care needs and their family caregivers, can expand self-directed care models, leverage remote technologies, and provide care at home. The SCAN Foundation so appreciates our partnership with the Alliance, HMA, and MNAT teams. And I am also thrilled to announce that our board just approved a major next phase of this important work. So over the next 15 months, these organizations will work with a diverse group of experts to prioritize the most relevant Medicare and Medicaid flexibilities for permanence, focusing on those flexibilities where policymakers can architect a more person-centered and equitable future for Medicare, Medicaid, and dual eligible beneficiaries. Thank you for allowing me to make these few remarks and for joining today's discussion. With that, I will now turn it back to Sarah.
Thank you so much, Dr. Mohanty. Really appreciate it. Appreciate our partnership. And as Dr. Mohanty mentioned, we're so pleased to be continuing this partnership in convening real solution-focused dialogues and educational events on this topic into the next year. And now I'd like to introduce today's panelists who will be giving opening remarks to frame today's conversation. First, Stephanie Anthony is a senior advisor at Manat Health. She provides research, analysis, and advisory services on health policy and health law to public and private sector clients. Stephanie provides counsel on healthcare reform, Medicaid, and children's health insurance program financing, program design and waivers, post-acute care, and long-term services and supports. She also advises on best practices in care management, integrated care models, and coverage options for the uninsured. Jennifer Podolka is a principal at Health Management Associates with extensive data analysis and project management expertise. Much of her work has focused on physician payment policy, traditional Medicare, Medicare Advantage, Part D, CMS Innovation Center models, the federal budget, and the broader healthcare system context for Medicare policy. Lisa Hayes is the executive director for Rolling Start, a center for independent living, serving people with disabilities in San Bernardino, Mono and Inyo counties in California. She also serves on the National Council for Independent Living's Long-Term Services Subcommittee and as an appointed commissioner of the California State Independent Living Council. Lisa brings over 20 years of experience in healthcare operations and contracting. She previously worked with Molina Healthcare, where she focused on shaping its healthcare delivery system to meet the needs of older adults and people with disabilities. Hamy Chawarson will be next, and she is the Executive Director of the National Academy of State Health Policy, a nonpartisan forum of policymakers throughout state government, learning, leading, and implementing innovative solutions to health policy challenges. Ms. Chawarson joins Nashb from the Duke Margolis Center for Health Policy, where she had led the center's emerging state policy portfolio, including COVID-19, vaccine distribution, coverage and health system reform, Medicaid system improvements, and addressing equity within and beyond the COVID-19 pandemic. Finally, we'll be joined on the panel by Jonathan Gonzalez-Smith, a research associate at the Duke Margolis Center for Health Policy, where he's responsible for helping lead the center's work on international models of accountable care, health financing, global health innovation, payment and delivery system reform. His research evaluates how to support health system transformation at the organizational, regional, national, and international level to achieve better population health while promoting efficiency, equity, and high quality care. And lastly, I'd like to acknowledge that Dr. Robert Saunders will be present during the Q&A session. Dr. Saunders is Research Director for Payment and Delivery Reform, also at Duke Margolis, where he directs a portfolio of payment delivery reform initiatives. And we look forward to having him at the Q&A. So we have a really great panel. We have a lot to cover. Don't forget to put your questions in the Q&A so that we can get to them throughout the broadcast. And let me, without further ado, turn it over to Stephanie Anthony.
Thank you, Sarah. So first, in our part of the presentation, Jennifer and I, before we start, we'd like to thank the SCAN Foundation for their generous and ongoing support of HMA and Manat in our efforts to track and assess how the Medicare and Medicaid programs have responded to the pandemic to support older adults and people with chronic conditions or disabilities. We'd also like to thank Sarah, you and your team at the Alliance for Health Policy, for your partnership in advancing the discussion on these really important topics and ways to strengthen our system for systems of care for these populations. You can go to the next slide. So Jennifer and I, in the next many minutes, are going to together go through what's on this agenda. I'm going to talk about, provide some background on how our work that the SCAN Foundation funded fits into the broader context of the COVID-19 related regulatory flexibilities, and convey what we learned from our research about some of the impacts of these flexibilities are having on consumers, providers, and the broader system. And then Jennifer is going to pick up and she's going to describe a person-centered assessment and decision-making framework for federal and state policymakers to use as they consider the future of the temporary reforms implemented during the pandemic, and then also elevate some high-value flexibilities for consideration for permanence. You can go to the next slide. Before we jump in to the lessons learned, I just want to provide some quick background and context on our work. So we do hear a lot about telehealth and the expansion of telehealth, which no doubt was a huge flexibility that was enhanced on both the Medicare and Medicaid side during the pandemic. But we want to just highlight that the federal government and the states really implemented hundreds and hundreds and hundreds of policy and regulatory changes, really almost on a dime back in 2020, to prevent disruptions in care for Medicare and Medicaid beneficiaries that were caused by the pandemic and the shutdowns and isolations and quarantines. These flexibilities provided broad relief for beneficiaries and providers to minimize administrative, clinical, and financial barriers to accessing and providing care, while ensuring protections for beneficiaries. These changes expanded program eligibility, benefits, and workforce capacity, authorized the use of alternative care sites, and expanded the use of telehealth, among many, many other things. Over the past 2 years, Manat on the Medicaid side and HMA on the Medicare side cataloged these flexibilities in various publications that are linked here on the right side. And in the we also have some content that I think is posted on the website that goes into a lot more details and specific examples of the flexibilities across each of these categories of activities. You can go to the next slide. So 2 years into the pandemic, you know, the first 2 years really just implementing and monitoring and sustaining these flexibilities, we're starting to see some flexibilities expire, such as the initial pause in the Medicare 2% payment reduction, and some made permanent, such as telehealth policies in Massachusetts and Pennsylvania, in addition to other states, and pharmacy scope of practice changes in Arkansas. That's just one example of a state that has made permanent some pharmacy scope of practice changes. So the past 2 years has provided an opportunity for us to test policies and practices that enhanced access to care for close to 140 million Americans enrolled in Medicare and Medicaid, including 12 million people who are enrolled in both programs, the so-called dual eligible population. And now with the end of the public health emergency, hopefully in sight, there's an opportunity to assess the impacts these flexibilities have had on consumers, providers, in the healthcare system, and consider which temporary flexibilities should expire, possibly to be reinstated in future emergencies, and which flexibilities enhance access to care and promote better quality and outcomes and should be extended, evaluated further, or made permanent. And this is, you know, as I just mentioned, already happening in real time. You can go to the next slide. So, as we all know, for a multitude of reasons, the COVID-19 pandemic has had a disproportionate impact on older adults, people with disabilities, populations and communities of color, and other marginalized populations. The pandemic reinforced that our healthcare system does not fully meet the needs of all people, as these populations faced higher rates of disease and mortality, disparities in vaccine access, and barriers to accessing essential services and providers. Simply put, the system is not delivering person-centered care or community-centered care in a way that advances health equity across diverse populations. These facts guided and underpinned the work Jennifer and I are going to talk about. And I will just say we did use specific definitions of person-centered and community-centered and health equity that are contained in some of our deliverables. We recognize there's a lot of different definitions, but the ones we used are contained in our final deliverables. You can go to the next slide. So using a mixed method approach and guided by the Communications Network Diversity, Equity, and Inclusion Research Framework, HMA and MNAT looked across all of those flexibilities that we had reviewed and identified those that best advance person-centered and community-centered care and better align Medicare and Medicaid for individuals and providers participating in both programs. We created an organizing framework for policymakers to use to assess the impacts of the flexibilities and make informed decisions about their future, and elevated select Medicare and Medicaid flexibilities for priority consideration by policymakers because they do advance person-centered care and health equity. The culmination of our work is contained in an issue brief and a shorter policymaker playbook. You can go to the next slide. Okay, some lessons learned from the pandemic from our research. Our first lesson learned, thank you. Our first lesson learned is that quantitative data on the impact of the flexibilities on consumer access, service utilization and outcomes, and on providers in the workforce is growing but incomplete. What does exist is skewed toward Medicare data, and then across both programs is centered around telehealth utilization data. This data does resoundingly show that telehealth utilization for both Medicare and Medicaid beneficiaries enhanced access to care in people's homes and communities, particularly for primary care, behavioral health, and some long-term services and supports, and really across all populations, although at varying rates across those populations. But from all accounts, more data is needed on the quality of care and outcomes from telehealth utilization and how different populations and communities have been impacted by the expansion of telehealth. Did it enhance access to care, or did it worsen existing disparities and access to, from access to broadband and other resources? And more data is needed on the many other categories and types of flexibilities that we have cataloged. In the absence of quantitative impact data, stakeholders that we talked to urged policymakers not to ignore qualitative data and stakeholder experiences, which are critical inputs to decision making. They also cautioned policymakers not to rush into ending a flexibility or making it permanent, but instead to consider extending flexibilities, as Congress recently did in the Consolidated Appropriations Act of 2022 for a broad array of Medicare telehealth flexibilities. And extensions like this could allow time for further testing, further gathering additional quantitative or qualitative data, and can signal to the market what's to come, giving providers and health plans and others time to prepare and respond. You can go to the next slide. Medicare and Medicaid telehealth utilization exploded at the beginning of the pandemic when in-person visits were just not possible or advisable. While telehealth utilization has since declined slightly, it is higher than pre-COVID utilization rates, and the lesson learned really is that it's here to stay. Across both programs, these flexibilities expanded the types of providers who could use telehealth, the services that could be delivered via telehealth, modalities of remote care delivery, including audio only and text-based communications, and they also authorized different originating sites for telehealth. There's clear data that Medicare telehealth visits substituted for what would have been no visits at all, meaning that telehealth visits offset what would have been larger declines in in-person clinical visits due to the pandemic. And on the Medicaid side, telehealth visits also expanded dramatically, particularly for telebehavioral health visits, which became a lifeline for many people as their behavioral health conditions worsened because of the pandemic. All states expanded their use of telehealth and telehealth modalities, including telephone only and text-based communications. From all accounts, the expansion of telehealth is here to stay, so a focus going forward should be on solving issues related to beneficiary supports and training, provider practice redesign and supports, reimbursement and parity issues, and eliminating disparities in access to telehealth while also ensuring access to in-person visits are not curtailed when necessary. In 1 second, I'm going to go through one more slide, and then before Jennifer starts, I was going to have her weigh in with some additional Medicare telehealth inputs, because there's a lot of data there and I want her to weigh in on that. But I'm going to quickly go to the next and final lesson learned before turning to Jennifer. And say, so at this point in time, it really provides an opportunity for policymakers to better align the Medicare and Medicaid programs for the over 12 million individuals and multitude of providers across the country that participate in both programs. Most of the regulatory flexibilities were implemented quickly across Medicare and Medicaid at the beginning of the pandemic to prevent immediate disruptions in access to care. In many cases, the regulatory changes aligned Medicare and Medicaid policies that were previously misaligned. For example, in row 1 of this graphic, which captures policies in a sampling of 5 states compared to Medicare, you can see that Medicare temporarily allowed people to use telehealth in their homes, which has been allowed by many states outside of the pandemic, prior to COVID. So while the Consolidated Appropriations Act has temporarily extended this Medicare flexibility, a reversion to pre-pandemic policies without deliberate review and thought or specific action could perpetuate ongoing misalignments between the two programs and unnecessarily, keep in place administrative and regulatory complexities for the providers who deliver care to the 12 million dual eligibles. So with that, I'm going to turn to Jennifer, see if she wants to weigh in on any of the Medicare telehealth flexibilities, and then continue on. Thank you.
Thanks, Stephanie. I would add on the telehealth side for Medicare, in addition to the data that Stephanie referred to, there are data that characterize the experience of people who are both in traditional fee-for-service Medicare as well as Medicare Advantage. And those indicate that while that share and total number of telehealth visits increased, the share was actually only about 5% of total visits, which means that while those telehealth visits substituted for what would have been no care, as Stephanie indicated, they weren't greatly substituting for existing in-person care. So when a Medicare beneficiary sees their physician every month or two throughout the year, maybe they're swapping in 1 or 2 visits during that time period. The data also indicate that the relatively small share of visits happening by telehealth is fairly evenly distributed across different groups of people by age, race, and ethnicity, and other characteristics. The one characteristic that consistently called for more telehealth use was dual eligible. And that means that people who are duly enrolled in both the Medicare and Medicaid plans tended to use telehealth more frequently than patients who are enrolled in Medicare alone. So back to Stephanie.
Great. Thank you to both of you for that. Stephanie, did you have any other comments, or because I did have a follow-up question, and while I have both of you, I think I'd love to ask this question before we move on to Lisa's presentation. Stephanie, you mentioned the importance of what stakeholders, particularly with an equity focus, really talked about, that we need to look at the quantitative data, but we also need to think about qualitative data. And I'm wondering, how can policymakers get access to that kind of qualitative data? Like, where should they be looking? What should they be looking for? And just more broadly than that, like, how do you see the trajectory of just the timing of, like, when will it be enough to sort of make a decision? How long is it going to take to really collect, analyze, and assess some of the key questions here?
So I'll start, Jennifer can jump in, but I think that whether it's federal or state policymakers, you cannot do this in isolation. There are consumer groups, consumer advocacy groups, providers, plans who have been literally living and breathing this for the past 2 years, who have real life on the ground experiences of how these flexibilities have been working. So the most important thing I think to do is to bring everyone to the table, to have discussions about some of the impacts. Some organizations are collecting data that policymakers may not know about, what quantitative data, but also, again, qualitative experiences, on the ground experiences, operational experiences from providers and plans that are just you can't capture necessarily in a long-term quantitative study, but are real information that can be used to informed policy making and decision making.
Great. Thank you for that. And I'm going to ask one clarifying question from the audience, which is timely to what you just shared. And the question was whether you looked at all at rare diseases, and the questioner notes that people with rare diseases needed care across state lines before COVID, will need it afterwards, and that telehealth made that possible during COVID. So any specifics there as far as rare disease, or people with other kinds of special conditions.
Mhm. I'll quickly say something, and then Jennifer, I'm sure you have thoughts on this, just from even somebody I talked to today in Massachusetts on these topics, this exact topic about the critical role that out-of-state providers and the ability, kind of the network expansion through out-of-state providers, or the use of out-of-state providers through telehealth was absolutely critical to certain people with disabilities and other chronic conditions, where they couldn't access providers in Massachusetts. They couldn't, and the only way to do it was through telehealth. And just having that ability to have an expanded network of providers at a time when there's such a workforce capacity issue across the services that are delivered and received by these populations was just critical. So I mean, I think it's going to be, that's one where you obviously want to be balancing and weighing beneficiary protections, making sure that people are qualified, providers are qualified, making sure that there's beneficiary protections in place. So there might be a little bit of further testing that may want to be done, but I think it's absolutely one that should be considered for longer term reform. Jennifer, I don't know if you want to weigh in.
First, I really want to thank the person who submitted that question. I think it's such a great issue for both Medicare and Medicaid programs to pay attention to. As you noted, rare diseases affect a significant number of Medicare and Medicaid beneficiaries, like they do for the rest of the population, and the needs there are kind of different than for everyone else. Although I want to note there's also some similarities. Medicare beneficiaries tend to see their physicians and other sort of chronic care providers mostly throughout the year. It's pretty rare for a Medicare beneficiary to not have some contact with a clinician. But big events like surgeries and other major procedures don't happen on a regular basis for Medicare beneficiaries. And I think some of those characteristics are similar for patients with rare conditions. If you want to get a serious procedure done, you're probably going to travel to a major hospital or a teaching hospital. That might be your preference. And probably your local provider is going to encourage something like that. In those situations, there's a great deal of follow-on care. And I've talked to so many people who said, that's a great situation for potential flexibility around telehealth, so that you're traveling over a distance to get a major procedure. And then that sort of regular follow-on care that proceeds over time. Some of that is by telehealth, some of that's in person. Some of it's maybe your local physician talking to the physician or surgeon or someone else at the site where you originally had the procedure done. So I think there are situations where we can basically apply telehealth as an extender for centers of excellence and linking local provider communities to centers of excellence.
Thank you so much. Okay, that was a great interlude, and we got deep into telehealth. And then Jennifer, I just realized you haven't done your slides yet. So moderator apology. We need to get you to your slides, and then we're going to hear from Lisa Hayes, who works directly with people every single day, day in and day out, and I'm sure she's going to have some stuff to say about this. So Jennifer, off to you.
Thanks so much, Sarah, and I will try to do this quickly. So if we jump to the next slide. We began this project recognizing, as Stephanie said, there had been hundreds of temporary flexibilities, and these presented a unique opportunity to learn about whether these benefited Medicare and Medicaid beneficiaries or if they didn't. We also recognized that the temporary flexibilities were implemented quickly under emergency authority, and regular actions, rulemaking, legislating, take a lot more time. So if we're going to focus on continuing either in a permanent or continued testing situation, we needed to focus on goals and the tools that would help policymakers determine how to proceed. So the tool we developed is a person-centered assessment framework, which is we hope, user-friendly tool for policymakers to use as they assess individual flexibilities. And we focused specifically on 3 goals so that we could sort of prioritize down to some of the flexibilities that showed the most promise first, for advancing person and community-centered care by meeting the needs of people and communities based on who they are, and mitigating program obstacles to care created or that predated COVID-19. Our second goal was the ability to facilitate care in the least intensive or least restrictive setting, but always based on a person's needs, goals, and preferences. And third, the policy's ability to better align the Medicare and Medicaid program rules to enable people to seamlessly access care regardless of their insurance status, and enable providers participating in both programs to deliver care quickly, nimbly, and uniformly. We've included some specific instructions for use, so if we jump to the next slide, I can talk about how that works. So the framework that we've developed in concert with stakeholders consists of 3 questions, or questions arranged into 3 sections. It begins first with questions focused on benefits and risks for key stakeholders such as consumers, communities, federal and state programs, providers, and health plans. And this provides some great examples of how we really refined this framework based on input from stakeholders. They stress the importance of asking questions about the impact of flexibilities on social determinants of health as standalone questions to focus interest there and research. And it was also our expert stakeholders who first elevated the importance of community-centered as an essential concept for assessing the effects of flexibilities. Section 2 of the framework includes a series of questions that help inform decision-making based on what has been learned about the impact and potential impact of the flexibilities. And then 3, we wrap with questions about which entities have the authority to potentially make temporary flexibilities permanent and the best pathway for pursuing that. So next slide, please. And let's go ahead and jump to the next one. So I'm going to talk about which of the flexibilities we focused on. And as I mentioned, we started off with 3 goals, and we applied these goals to filter down from our hundreds of flexibilities to ones that we wanted to draw your most attention to. And these flexibilities fall into 3 categories plus an other category. So first is expanding the telehealth benefits from what was allowed before COVID to some version, perhaps a modified version of what was implemented in response to COVID. Second, modifying scope of practice and workforce requirements in the programs. Third, modifying Medicare Advantage requirements. And then our 4th category includes a Medicare policy related to the 3-day SNF rule, as well as 2 Medicaid flexibilities, one on self-directed home and community-based services and the other on long-term services and supports. So if we could jump to the next slide, please. And Stephanie and I wanted to very quickly at a high level walk through what this might look like applying the framework to a specific flexibility. So just as an example, I grabbed the one that says allowing physicians and non-physician practitioners to provide services in states in which they are not licensed, and walking through the different benefits. One, this benefit could include improved access in cares in states where there are currently limited participating providers in the Medicare program. Secondly, it could serve to advance person-centered care by allowing beneficiaries greater choice in their providers. And third, it advances equity by enabling beneficiaries with fewer financial and other resources to access care at distant centers of excellence. These benefits are, of course, weighed against risks. So our first risk is potential risk of over-reliance on out-of-state providers may end up perpetuating small provider networks in rural and other under-resourced areas. Second, greater disparities for rural and other under-resourced areas with less access to broadband technology. Third, the risk for fraud and abuse. And finally, there's a great number of other considerations, but we wanted to highlight perhaps the most significant one for this policy would be a significant political challenge from provider groups and others. Then we discussed the potential authority path for having this policy extended. So let me jump and have Stephanie weigh in because our next slide deals with Medicaid.
Sure, and I will be quick. I know we have other speakers to get to. We did highlight a Medicaid one that we thought really is kind of represents the essence of person-centeredness, which is the expansion of self-directed home and community-based service opportunities, which is allowed currently under many existing Medicaid authorities, whether it be 1915C waivers, some of the newer home and community-based service state plan options, 1115 waivers. So this can already be done, expansion of self-directed HCBS, home community-based services, as well as who individuals can hire to provide those services. So, you know, we really thought this flexibility particularly really, again, is kind of the essence of person-centeredness, because it also helps fill in workforce capacity gaps, helps with addressing health disparities to the extent the individual hires people who it might be in their communities, look like them, have the same cultural and linguistic preferences as they do. So really it can be used for advancing health equity. The only thing I would say is that there are so many others. I'm sure we'll, you know, that we just pulled out 2 examples. So we hopefully can talk about more in the next, when we get to the Q&A. And I think just on the last slide, we just wanted to say more data and collection and analysis may be needed for some of these. Remember, there's a third option, which we, instead of, you know, just unwind or make permanent, but explore a little bit further, test a little further. And there's a lot of other researchers in the field funded, and we're going to hear from some today, funded by the SCAN foundations and others that are contributing to ideas for flexibilities for permanence. Thank you.
Great. Thank you so much, Jennifer, Stephanie, for that joint presentation. Super helpful. And now, without further ado, I'm so pleased to introduce Lisa Hayes, the Executive Director of Rolling Start, Inc., and which is a Center for Independent Living. Lisa, welcome. And
thank you so much. Sorry, I hope you can hear me okay.
All set.
Awesome. My name is Lisa Hayes. I am representing the National Council on Independent Living today, and I'm also the Executive Director of Rolling Start, which is a Center for Independent Living in California, serving the San Bernardino, Inyo, and Mono counties. So I'm so excited. First, I want to just thank the Alliance, SCAN Foundation, Manat, for allowing us to present this side of what it really looked like, some of these flexibilities, what they look like on the ground, on the street, and how our consumers were affected in managing the pandemic. So we can go on to the next slide. So NCLL, as we are typically called, we're the National Council on Independent Living. We're the longest running national cross-disability grassroots organization run by and for people with disabilities. We feel that's a unique perspective. Typically our boards of directors are predominantly people with disabilities. The people that run the centers for independent living are people with disabilities, and you know, our governing bodies. So we have a unique perspective, a peer model that has worked for many years, and know this is a proven model that really serves well. NCLL represents thousands of organizations and individuals throughout the United States, individuals with disabilities, centers for independent living, the state independent living councils, and any other organization that advocates for the human and civil rights of people with disabilities. Go on to the next slide. So the CILS, the Independent Living Network, we are consumer-controlled, community-based, cross-disability, non-residential, nonprofit agencies designed and operated by people with disabilities. I know that's a mouthful. We are funded to provide 5 core services: information and referral, peer support, advocacy, independent living skills, and transitions. Transitions, just for clarification, are transitions from nursing facilities to community. We also do assist from hospitals to community, but the goal, of course, is to get people independent in their own communities in the setting that they prefer. We serve all ages, so, you know, is from birth to death. I mean, I think here at Rolling Start, the oldest consumer we've served is about 105 years old, getting services, and it's very, and the youngest is probably, I think in our center is probably about 3. Most of our consumers are low income, people living below the poverty level, undocumented folks, people managing chronic conditions, and of course, utilizers of Medicaid, Medicare, and duals. We don't typically focus on knowing if they have Medicaid, Medicare, or if they're duals, but often it helps us coordinate services, especially with the health plans that they're assigned to. And I just want to also real quick make sure we identify the folks that we serve as consumers or clients, largely because, and I know a lot of the medical community identifies our folks as patients. We try to stay away from the medical model, being more person-centered and looking at people outside of the clinical encounter, which is why they're similar. I just want to make sure you understood we're talking about the same folks, the consumers that we serve. So traditionally, before pandemic, our services were in person. Many folks come in with some issues. We'll do an intensive intake process, help them identify they tell us what their goals are. We devise person-centered independent living plans. We do one-on-one support. We're really known a lot for our group support, social supports, and we do a lot of follow-ups, 30, 60, 90 follow-ups for all of our consumers. Go to the next slide. So addressing social determinants of health in a pandemic. So, some of the flexibilities that were extended to the CILs were, from our federal and state partners, where we'll continue to fund you if you can figure out how to serve and provide these services to folks in a quarantined environment, which was extraordinarily challenging for a lot of us. I don't think, as a community-based organization, we had probably very similar challenges as a lot of folks did. We had an unprecedented amount of collaborations with health plans and all the other community-based organizations. We had to address the digital divide, and that you're going to probably hear a lot about that today. The digital divide, people who could access technology, it worked really well. But we were dealing with consumers who did not have access to broadband. They're low income and couldn't afford internet access. We work with a lot of seniors that thought they would get through life without using a computer, and realized that they've got to figure this out. And we were able to, with some generous funding, to get computers out to folks, to provide the training with a lot of folks. And it had been, for those who were able to access, was a game changer. I've got, an 86-year-old consumer who says, she loves being able to email. She loves being able to see the world through YouTube. And some of the things that she never thought possible, just having access to the internet and access, having a computer and learning how to do it was, changed her whole perspective on life. But then there are others who live in some of our high desert areas where there is no internet access. So we really do need to kind of figure out how we can broaden that digital divide. We had to manage fear, like a lot of folks living in social isolation, a lot of people really afraid to have people come into their homes. I can share a story of someone who I Zoomed with about a month before she passed away. She was deathly afraid to have her caregiver come into her home because she wouldn't wear a mask. She had advanced stage MS. She ended up, in the hospital and didn't make it. And it was a really sad situation, but there was, early on in the pandemic, we couldn't get, people didn't have access to PPE, gloves, masks, hand sanitizers. We had to, address that, and fortunately we were able to do that. People afraid of healthcare rationing. I know that in particular, we had a consumer he had an intellectual and developmental disability. He was a senior. He called us, he was in the hospital and he had COVID, and he told us about, the doctor told him he was going to get these 5 rounds of, I think it was remdesivir or something like that. And they were, after 2, he was crying because they were going to send him home, and he goes, they're not going to give me the rest of it. And they're sending me home, and they expect my caregiver to pick up, but my caregiver doesn't want to get COVID, so I don't know how I'm going to get home. So it was, a real big challenge. We really had to engage his health plan to, get some serious advocacy. We ended up getting him home safely and getting the remainder of care that he needed in his house. So, but, this was just a very common story that we heard, that people weren't going to value people with disabilities because of their disability. A lot of, as I mentioned, fear of getting it, getting PPE needs to consumers, to caregivers, to family members. These were, a lot of things that we were trying to manage. Some of the gaps, of course, identified is the consistent caregiving. We had a real problem with backup provider shortages. If your caregiver got sick, we didn't have enough backup providers to get out to serve the needs. I can tell you a story of a consumer who spent nearly 5 months without her needs getting met because she could not get a backup caregiver, and her regular one decided they weren't going to go and see consumers anymore because they had their own families to be concerned with. And these are real stories of people on the ground, going without the care that they needed. This person ended up with pressure sores and is having surgery because of that. Access to food. We never thought as a Center for Independent Living we'd be in the business of food and getting food out to our consumers. So it really required us to be flexible in terms of, finding where we can, access food at a lower cost, collaborations with our health plans to help us with this, meeting special diet needs of consumers. People couldn't get transportation. Paratransit was challenged. You had to schedule something 2 weeks in advance in order to get, if you needed to get anywhere. And even that was, people were afraid to do that. So getting access to food and getting it into their homes was a big challenge. Access to assistive technology to avoid, any nursing facility placements. We know what was going on in nursing homes. Nobody wanted to go or end up in a nursing facility when you heard the massive amounts of people that were getting infected. So assistive technology could be anything from, getting them a walker, a bedside commode, canes, some kind of threshold ramps or whatever they needed to get, be able to stay as independent as possible. We would get that to our consumers. A lot of people, people with disabilities and older adults are people first. Family members were moving in together. Rent was not, people were having challenges in meeting their basic needs because of a lot of things going on with COVID. People with disabilities that lost their jobs because of COVID, and we needed to provide rental assistance, utility assistance. Vaccine prioritization, that was a big one. When the vaccine became available and people with disabilities were not given priority status, that was really, really hard. It was a lot of folks, there was a lot of advocacy around that, and we really need to, and I understand on a level of why there was a data issue. They didn't have the data to know that this was important, but we heard this all over, people wanting to get vaccinated and couldn't get vaccinated. Home health and in-home vaccinations was, a big advocacy push, which happened eventually. Getting care in the home was critical, and these kinds of things really need to continue. These flexibilities need to continue. We can go on to the next slide. So, some of our recommendations kind of going forward, home and community-based services, as you heard earlier, is extremely critical. We, as far from our center's perspective, we, the digital divide was obviously was big, and trying to bridge that, and it allowed us to see consumers that we were typically may not have been able to get to our offices, and to provide services to them either through video or telephonically. We need to get sustainable wages for caregivers. We need to figure this out in terms of, I think it was just probably one of the biggest, challenges that we had is getting consistent caregiving, getting people that wanted to get out and to help the consumers. The alternative is nursing home placement, and nobody wants that. So, figuring out this backup registries, getting backup providers. We need to, this needs to be something that's a priority. Housing is really huge. I want to tell you just, even maybe not a result of the pandemic, I'm not really even sure, but lately more seniors and people with disabilities are homeless. And the reason for that, part of it is due to the housing market. Rent owners that have rentals want to get more money for their properties, or they want to sell it and take advantage of where the market is. But it's pushing a lot of seniors out. And not because they're on limited incomes. There are people living in their cars, people living, getting mobile homes or trailers so that they can live in, because they don't have any alternatives. We need permanent authorization of money follows a person. We found, and now even more than pre-pandemic, more people wanting to get out of nursing homes. And I feel like we're chasing money follows a person on it gets a 30-day authorization, a 90-day authorization. We need permanent authorization of this, because there are a lot of folks that, we can help transition out that will have the opportunity to live the Olmsted dream and to live in the environment of their choosing. Utilization of community health workers to support health education, to support getting stuff to consumers, I think would be a huge help to a lot of the consumers that we serve. Long-term supports and services, you're going to hear a lot about that today, but we need to look at it from a broader lens. Yes, long-term supports and services is the waivers and getting, all the specialized community waivers that are out there, but the home care providers. But we need to look at it in terms of emergency preparedness. How do we prepare our communities for the next pandemic, for the next major earthquake, for the next whatever? How do we, addressing the digital divide, we've got to make sure people have access to technology. We've got to make sure that, there's recognition too of rehabilitation programs like what the centers provide, that really provide the round, services that outside of the medical, clinical encounter, everything that makes a person human, everything that, allows that person to have a normal life, recognition of the community-based organizations like the SILs that are providing this. And that's about all I had to offer. If you have any questions, there's some folks to contact from Nicole.
Thank you so much, Lisa. That was a really, really stark and deep overview of what life is really like out there and how policy can affect it. So thanks again. And I apologize, everyone, we're running a little bit behind, but there's so much great content. So I'm now going to turn it over to Hammy Torson to talk about what's going on in the States. Hammy, thanks for joining.
Hi, Sarah, and thanks so much to the Alliance and SCAN Foundation for having me here. I'm Hammy Torson. I'm the Executive Director here at the National Academy for State Health Policy. And so next slide, please. Just wanted to bring a slightly different perspective to the conversation today, which I think is a very important conversation about where we go next with all these flexibilities after the end of the public health emergency at the federal level. Just for those of you that aren't familiar with Nashb, what I'm going to talk about is what I really hear from the members of our academy. So we are of buy-in for the states. And really, I think what's unique about Nashb is we work with all levels of state government. So we work with legislators, we work with governor's offices, we work with Medicaid directors, we work with public health officials, we work with social services agencies. And so we really do have a broad perspective on, frankly, COVID-19, the recovery from COVID-19, and all these pieces that are really involved in really recovering. So maybe next slide, please. What I wanted to do is just paint a broad brush of, talking to our members of our academy, in which we have over 60 state leaders, and we have various work groups in all these different areas that were mentioned earlier today, including focusing on aging and disabled communities. And really talking to them, we asked them, what are really your top priorities? And I thought it might help just to set that frame of what those priorities are, and then how they flow into the thinking around what states may do after the federal public health emergency ends, what they're already doing and what they may do. So at the top of the list is healthcare workforce. And really, I've done state health policy for a long time. Healthcare workforce was always an issue, but it has come to the forefront in a way that I haven't seen before in many, many years. And really, it's really different types of workforce. There's concern around, nurses and hospital staff, given kind of what we experienced through COVID and the departures we're seeing in that profession. But there's also a real need for workforce in the long-term care arena, which I think is very integral to this discussion of, how do we really think about or rethink how folks are doing in nursing homes, their interest in staying at home, what kind of workforce will be able to support that, what are the improvements to the system to be able to sustain that. And I think thinking about these flexibilities play into that piece, but it's a sort of a bigger, I think, quandary that states are trying to solve. Behavioral health has really risen. It always has been a challenge, both on the mental health side and the substance use disorder side. But the pandemic has really, I think, driven some of these levels to crisis levels. And I do think thinking about the flexibilities, especially in the telehealth and scope of practice realm of how do we really get more behavioral health providers and more services to people is a really part of the big part of the conversation. Cost of healthcare. So state leaders are always wanting to make sure they have sustainable budgets. Unlike the federal government, they actually have to balance their budgets and have to make sure they're accountable for all the dollars, generally on a year-to-year basis. And so one of the things that has come up historically is, how are we doing with our spend on healthcare? Medicaid has become a bigger and bigger piece of the state budget. But there also has been, I think, some concern on how are consumers affording their healthcare. And so thinking about how those two relate with respect to thinking about what comes next in this pandemic and with the flexibilities that we're talking about today, I think is also important to consider. Public health, where are we going next to really modernize our public health system, connect public health to the other parts of our healthcare system, thinking about how we can do better, how we can be prepared, both in serving our populations, if there's another pandemic, another disaster. And I think a focus on sort of the aging and disabled populations in particular is part of that conversation. And again, I think some of these flexibilities play into that. And then social determinants of health and equity has certainly come up as a priority area, both in how do we invest in those different pieces that we know all amount to better health, and then how do we really have better connections to communities. And I was really happy to hear those last remarks of what is a community experience of this pandemic. And it's been hard. It's been a hard 2 years. I think we've learned a lot. And I think we, at least state leaders, are really trying to understand what are our lessons learned, what are the things we double down on and that we continue to do, and what are the things we need to improve upon. So I wanted to just provide that perspective. I also wanted to note, just on the fiscal piece, some of these flexibilities, if they are made permanent, they do have fiscal impact. And so I just wanted to mention on the state budget side, most enacted state fiscal 2022 budgets include an increase in both state spending and revenue. So that's good news for states. They have money to spend. They have more flexibility to think about the programming. I think there was a fear that state revenues would be cut dramatically and that states would have to scramble in order to make up those deficits. But I think because of the federal stimulus dollars that put money into the economy, personal income tax wasn't impacted as heavily due to higher income individuals being insulated. So, and tax from goods were mostly unaffected. So good news for states in the short term. I think the other piece is states are continuing to get an infusion of federal funds through things like the American Rescue Plan Act. And they're really thinking about how to continue to spend those. Some have decided already, some are in the midst of deciding. And I think that also plays into how we think about some of these flexibilities in the longer term. Okay, next slide, please. I did want to also just mention, here at Nashb, we track governors and legislators and Medicaid officials and all those folks doing all the different programming. On the gubernatorial level, we do have 36 states electing governors in 2022, and 8 of those elections are guaranteed to result in a new governor. And I just mentioned that because it could be a year of significant transition if some of these governors don't get reelected, and that always has an impact on programming and policy. And so, how we think about what's being done now and sort of building the bench and the knowledge base at those who are not sort of the political level to understand the need for different types of flexibilities to be extended and what the program implications are, I think are really important to carry into potentially new administrations that may come into office in 2023. Okay, next slide, please. Okay, so I won't go through this whole slide because I think Stephanie and Jennifer did a wonderful job talking about some of the flexibilities that states have been taken advantage of as a result of the pandemic. But I did just want to mention a couple of things. So, we are very focused on Medicaid and CHIP declarations of flexibilities as we work with the state policymakers. And a couple things just to note, states really implemented wide-ranging changes to their Medicaid programs in response to COVID-19. And, the type of authorities that they use, they're just listed at the top, 1135 waivers, disaster spas, 1915K, Appendix K, 1950C, Appendix K, et cetera. And all of those different flexibilities have different timelines. So some, depending on what authority they use, some will end along with the end of the federal PHE. Others will end 6 months after the PHE ends. Still others go out farther. It could be the first calendar quarter at least 1 year after the PHE ends. So there's a lot of different timing components, and states are having to track all of that because there are all these different authorities. I think of the categories, states can make, and some of them have already made many of the changes permanent through things like a state plan amendment or Medicaid waiver demonstration if they choose to do so. And states are making these determinations on a state by state and program by program basis. And just at a high level, what were the type of flexibility states implemented? Eligibility and enrollment, and I know we're not going to talk about the continuous Medicaid eligibility that will end once we hit the end of the federal public health emergency. And I just wanted to note that is a huge looming challenge for states and probably their number one issue as they think about end of the public health emergency. So I just wanted to highlight that. I know we're not going to talk about that today, but it really is, I think, a big task for states and probably, the biggest enrollment event they're going to have in the short-term, long-term future. But the other things that they did was supporting the workforce and reducing barriers to enter the Medicaid program as a provider, adding or adjusting benefits and service provision rules, and reducing administrative burden, barriers, access to care, and timeframes for administrative processes, and a lot of different flexibilities related to long-term services and supports and home and community-based services, which I think were driven by the need of people not being able to reach services, not being able to leave their homes, having all those limitations that we just heard about at the individual level. So one of the things I wanted to talk about, maybe next slide, please, is just drill down into a few of these buckets. And so we can go to the next slide. So I wanted to just talk a little bit about telehealth. So I think we all acknowledge and have been talking about how the pandemic has really changed how we're experiencing healthcare, and telehealth is a big part of that. And telehealth is here to stay. It's been built into the service provision. Consumers like it and are using it. And so I think states are thinking about how do we consider making these changes permanent? Do we make them permanent? What are the considerations? So what I thought I would do for this slide is just talk a little bit about what states have done and what they're considering about doing to make some of these more permanent. So they had a number of different flexibilities, and those were tied to the federal public health emergency. One bucket was many states relaxed or waived requirements for in-state licensure for providers, or granted temporary licenses for out-of-state providers. They had to. They did not have the workforce. They had to have new ideas and new ways to provide services. And a number of states are making those changes more permanent. They're creating new pathways for licensure for telehealth. They're participating in interstate compacts that will make that a more permanent option, while at the same time others are retracting their licensure waivers and flexibilities because they do want to do more thinking about what makes sense in terms of who can operate in my state. I think a number of states implemented temporary payment parity for telehealth and in-person services. And just reflecting where we are now, there are 19 states that are implementing payment parity on a permanent basis. And 4 additional states are doing so with some caveats that's only for specific services and it was specific sunset. So I definitely think, my view is, all the work we've done on telehealth before the pandemic, we've made so much progress over the past 2 years, probably, 10 years worth of work that we've done beforehand, and we are now at a different place. I think during the pandemic, many states have expanded coverage for telehealth modalities to include telephone only, text-based communication, and remote patient monitoring, as well as authorizing patients' homes as an originating site. And I think you're starting to see a number of states are, on the cusp of really making some of those authorities permanent, such as allowing telehealth from a patient's home under Medicaid, and a couple of states have made permanent the ability to use audio-only telehealth under Medicaid. And then the last bucket I wanted to just mention is, back a slide, is most states expanded the type of services eligible to be delivered through telehealth for the Medicaid program. And many states have made that permanent for Medicaid providers to bill for services. A couple of things just to talk about, okay, but not all the states have done it, and where are they going and why? So we had roundtable discussions with state leaders around what are you going to do with telehealth? What's your next steps? And a couple of things I just wanted to share with you all. A pro obviously is we need more access for individuals. We have a limited access to providers, especially specialty providers in their geographic areas, behavioral health, specialty disease experts. Those with disabilities or other conditions benefit from technology-enabled visits. We heard that from Stephanie and Jennifer. And there are many with transportation access limitations. So those are all the reasons why move forward. But there's also concerns on the flip side of, are we really going to hurt our networks? Are we going to limit the ability of in-person care? Will the insurers manipulate network adequacy rules and limit access to in-person options? Is there going to be a shift of low-hanging fruit patients to remote care, leaving the more expensive and demanding patients to in-person providers? And does that further stress the system? And how do we think about access to out-of-state providers, including licensing standards, and how do we have appropriate oversight over those providers in the long term? I think the other thing is they are thinking about how do you incorporate a mix of telehealth and in-person delivery options. So like they brought up questions about for required well-child exams, what elements of the exam make sense to be delivered remotely, but what should still be in person? How do we, as an oversight agency running this program, how do we make sure we're doing the right thing? And there's two concerns also about equity. We don't want to exacerbate equity concerns. So how can we optimize how telehealth can be used to improve access, but where might it not improve access? And, if you read the state of the states, some governors are really investing in broadband and working with their legislators to think about where's broadband not reaching certain populations in our state, and how do we do that as a first step? And the last thing I'll say is on the behavioral health side, I think the data has shown that telehealth has exponentially increased behavioral health services, and right now we are in a crisis and we really need that. And so I think states feel like, okay, we do want to continue telehealth. I think the question is, how do we do that? And how do we make sure we have an adequate network? Okay, next slide, please. I want to talk also just briefly about workforce. So as I said at the top of my remarks, healthcare workforce has become the pressing issue. And so during the public health emergency, states took advantage of the flexibilities that the federal government offered, and they did a number of things. They increased reimbursement and allowed interim or retainer payments to providers through Medicaid. They relaxed provider licensure requirements and licensure for outer-state providers and provider screening requirements, not just for telehealth, but also more broadly to allow folks to enter the Medicaid program. They allowed services provided by graduate clinicians. They reduced the need for direction by physician or dentist when practicing within scope of practice. And so I think the question is, what are states going to do? And I think they're really balancing the immediate access with quality, local, and right care considerations. They're also thinking about the cost of payment increases. Can that be sustainable over the long term? And I think there's also some political implications. For example, on scope of practice, that has been a long-standing sort of political battle about, who should be able to practice without supervision. And those concerns continue to be raised in legislatures across the country as this conversation is going on. I think the other thing I wanted to just mention too is states are also pursuing expanded workforce initiatives, and they're thinking about how that fits in to telehealth, scope of practice, and all these other reforms, and looking at it holistically about how do we really create a package of reforms where we're really going to shore up the workforce in our state. And just to mention a couple of things, there's things like scholarships and loan forgiveness that states are thinking about, recognizing out-of-state licenses, expanding training programs, increasing compensation for certain parts of the healthcare field. On the home and community-based services side, which I'm going to talk about in a minute, there has been a lot of consideration of increasing rates and how we do more with that workforce. I think there's also some considerations at the gubernatorial level of how do we attract different education programs and train more and make sure we're having the right pipeline to reach the workforce that we need. So if you're interested in any of this, we actually went through each state of the state governors, and they've mentioned a lot of different pieces in different ways of how to address workforce, and that could be something, if you're interested, we can follow up on. Okay, and then the last I just wanted to mention was just talking a little bit more about home and community-based services. I think for this conversation, so relevant. And so, you know, I won't go through all the different flexibilities. We've talked about that. Really, I think have been just really shown how people who are aging or disabled, who require services in the home, what we've been able to do with the additional flexibilities has really made a difference. I think one of the things states are doing, they're thinking about, okay, do we extend these flexibilities permanently? And some of the considerations are, we need more data. What were the impacts on utilization, cost, and quality? So I was so happy to hear earlier in the conversation about researchers really digging into this to understand what the impact has been. What was the feedback from enrollees and families? What worked, what didn't, what tweaks need to be made? How did these changes impact waiver capacity? Were we actually able to serve more? And is that sort of a way to think about how we reduce our waiting list for some of our home and community-based services waivers in the future? And then how does this overlay with all of the different reforms that states are thinking about with the enhanced dollars that they're getting for the home and community-based services? And as part of the bump, which is, you know, the increased FMAP by 10 percentage points that's in place from 2021 through 2022, but they'll have until 2024 to spend the funds. States are planning a lot of different things. They're thinking about increased wages and benefits for the HCBS workforce. They're investing in training. They're incentivizing recruitment and retention payments. Their service expansions, home modifications, assistive technology, meals and nutrition, transportation, caregiver support, self-directed services, et cetera, technology for providers and state agencies, adding waiver slots, making assessment changes and eligibility changes. And I think all of that is also related to what do we think about with respect to extending the flexibilities that we have made possible through the temporary waivers that we have through the federal public health emergency. So I guess I'll just sum it up and I'll turn it back to you, Sarah, that I think for states, there's a lot of different considerations of how all these pieces fit together. They are looking at things from sort of a totality of circumstances of, you know, federal funding coming in. We have a big enrollment challenge looming. We're trying to sort of address all of these immediate needs across workforce, across modernizing public health, across, you know, equity, and how that all fits with these authorities, I think is the challenge. And I'm really happy to see this in-depth work. So states will have more to think about in that respect. So that I'll turn it back to you, Sarah. Thank you.
Thank you. Thank you so much, Hammy. And I'm going to turn it right over to Jonathan now for his presentation. Hopefully we can fit in a few minutes of questions. Jonathan.
Great. So thank you, everyone. I'm going to try and run through these remarks very quickly. I'm Jonathan Gonzalez-Smith. I'm with the Margolis Center for Health Policy at Duke University. I'm going to be speaking on the flexibilities, particularly within the context of home-based care. I'll try and provide some top-level remarks on the landscape of home-based care, examples of how these were impacted by the pandemic-related flexibilities, and then some of the broader implications moving forward. I'll also note that Robert Saunders is joining me in the Q&A, and that my remarks today are part of a larger project funded by the Commonwealth Fund, the SCAN Foundation, and the John A. Hartford Foundation to identify short-term practical policy recommendations for expanding home-based care, and we're very appreciative of their support. So to begin this conversation, I'd like to take a step back and describe why I'm talking about home-based care, what it is, and why it's relevant to today's conversation. As we've heard from others, there were a number of flexibilities introduced during the pandemic that expanded where people were able to get care. We've heard a lot of about telehealth, but there are also a number of other flexibilities that allow care to be provided directly in a patient's home. One of the more notable examples is hospital at home, which I'll discuss in a little bit. But before I do that, I'm going to describe a bit more about home-based care more generally. So, and again, apologies if I'm rushing through this. I just want to leave some time for Q&A. So home-based care is a broad term. It encompasses a variety of ways of providing care in the home setting, which can include managing a patient's medicine, providing physical therapy, or social services like transportation or food. Over the last 2 decades, there has been a substantial shift to providing more home-based and community-based services driven by patient preferences, advances in technologies, as well as changes in how some of these services are regulated and paid for. But despite this growing trend, there remains a significant gap between the demand and supply of home-based care, with an estimated 7 million Americans unable to access home-based care services due to a number of reasons. First, it's expensive. It requires a lot of time and resources to go to patients' homes. Second, and related, the way that we often pay for health services can be an impediment. Many people have noted already the fee-for-service payment model, wherein you get reimbursed more services you provide, but in the context of home-based care, this can leave providers with less revenue since they're spending more time traveling and therefore seeing less patients. And then third, there are a number of regulations that can limit who can provide care in the home setting and what types of services can be delivered outside of the clinic. For instance, prior to the pandemic, Medicare didn't have a reimbursement mechanism to pay hospitals for providing hospital-related care in the home setting. But in the response to the pandemic, many of these regulatory and payment barriers were changed to allow services to be delivered outside of the clinical setting. As an example, CMS created 2 waivers that I'll speak on, like the Hospital Without Walls waiver, which allowed Medicare to pay health systems to deliver hospital-level care in the home setting for certain services. Prior to this, many of these services weren't reimbursed. And as a result, we saw a dramatic expansion of around 12 programs existing prior to the waiver to more than 140 programs after the waivers were introduced. This rapid change created momentum for home-based care services more broadly, and it also is tied into a larger strategy across Medicare, Medicaid, and other stakeholders to expand not just hospital-level services, but a number of other home-based care services as well. For instance, the Center for Medicare and Medicaid Innovation has been strategically evaluating their portfolio of models, and as part of this, they've been very explicit on the need to expand access to home-based care services within their model design. So there's a unique policy window, which has been some of the impetus for our work, and there's also a significant appetite for this type of home-based care. But moving forward, there are a number of things that we should consider as we think about making these flexibilities more permanent. I'll name a few, but note that there are many more considerations. First, we need to be mindful of how these flexibilities fit into the broader healthcare delivery system. One of the challenges that we've remarked in some of our policy briefs is that there are a lot of diversity in home-based care models, but there isn't a lot of coordination across these models. For instance, when a patient is discharged from the hospital at home program, there isn't necessarily a seamless transition or follow-up back to the home-based primary care setting. This can lead to gaps in care, which might detrimentally impact patient outcomes. And so we need to think about ways that programs like hospital at home and some of the flexibilities around expanding access to the home-based care setting could be expanded without leading to more fragmentation. Second, we need to be mindful of equity considerations when expanding these flexibilities. Lisa and others have mentioned the digital divide, so I won't go into this in detail. But echoing what many of the other panelists have said, and noting that many individuals don't have access to the resources needed to benefit from telehealth or may not have family or caregiver support. Third, we need to consider the financial implications and how we will pay for some of these services. For instance, in the hospital at home program, Medicare paid hospitals the same rate for providing care in the home setting as in the hospital setting. And this was appropriate to sort of scale up really quickly, but in the long term, we need to think about whether this is financially sustainable, whether it encourages more coordinated or fragmented care, and whether it encourages the type of care that leads to better patient outcomes. And so sort of putting this all together, one of the things that our team at Duke has been thinking about is whether there are alternative ways of paying for these types of services that might be more appropriate. For instance, value-based payment models are one approach that have been increasingly seen as a better way to support home-based care services. Under value-based payment models, providers are paid for the quality, not the quantity of care delivered. And there are a number of different ways of doing this, which I won't go into, but one of the benefits, at least in the context of home-based care, is that they offer providers flexibility to deliver care tailored to patient needs while ensuring accountability for patient outcomes across the different variety of care settings. And I think this is a really critical element that often gets overlooked because the conversations around sort of the future of flexibility seems to be primarily binary. Either these flexibilities will be renewed or they won't. But there are a number of value-based payment models that have actually enabled these types of services to be provided already. And we've seen this with some organizations participating in total cost of care models, providing home-based care services prior to the pandemic. So in wrapping up, one of the things that my colleagues and I proposed in our recommendations is that as we move out of the pandemic, we need to consider ways that existing payment models can support the range of services that an individual might need as their health and social status changes. Sort of three top-level recommendations. First, these models must support accountability and coordination, which I've already discussed, but it's particularly important as we think about ways to integrate the pandemic-related flexibilities into the broader fabric of the healthcare ecosystem. Second, we don't need to reinvent the wheel. There are a number of existing models at the state and federal level that can be leveraged to support home-based services, whether through Medicare Advantage, Medicaid 1115 waivers, or the recently announced ACO REACH model. And third, we must ensure that these models are accessible to small independent care providers with limited resources. So I'm going to cut my remarks short and provide some time for Q&A. I'd like to thank everyone for the opportunity to speak, and I encourage everyone to go to our website to see our recommendations. And we've also published an article on health on Forefront that summarizes some of our recommendations. Thanks.
Thank you so much, Jonathan, and sorry for you to have to cut your remarks short. Let me invite everybody now up for about 10 minutes of Q&A. And I want to pick up on something you said, Jonathan, and Hammy also alluded to, right? Like this idea of there isn't like this dual aspect of permanence versus going away. Could be a lot of middle ground. And then Hammy, something you talked about, with regard to the state elections. I wonder, my question for the panel is kind of a process question, because what strikes me in everything that you all have talked about is the hundreds and hundreds of decision points, data points that need to be addressed and thought through across multiple layers, local, state, federal, jurisdictional. So this is a huge information transfer, decision support and continuity question. And so what I'm wondering, if you could comment on what do you think is the best way to support policymakers as they think through these multitudes of questions? And Jonathan, I'll let you go ahead and start since you were last.
I actually might turn to Rob to help answer this question first, if that's okay.
Yeah, and happy to. And so I think, Sarah, you bring up a good point that there is a lot of planning that goes into all of these steps. I mean, even as we talk about policy, there's a whole workforce or army of folks who will need to actually respond to said policies and be able to move and to practice. And so there's some timing challenges here as we do it. I think the one point that Jonathan flagged that I'd want to double back to is that there doesn't necessarily have to be an all or nothing consideration here. There's a lot of middle ground options that can continue these flexibilities in some form, can provide the flexibilities where there's appropriate need for them, while recognizing that they may look differently in a non-public health emergency time frame as in a public health emergency. So I think that's a top line point here. But Jonathan, are there parts that you would add to that consideration?
No, I think that's great.
Anyone else would like to comment on that?
I think the only thing I would say from a state perspective is the timeline. So as I said, some of these expire 6 months after the public health emergency, some expire when it ends. So there really is a different time frame. And just for planning for state legislative sessions, I just wanted to add that into the conversation. So all the work is done in a very short time frame. I mean, some state legislative sessions are January to March and you're done, right? Some are longer, some go through May. And really the work for, I think, policy influence is really before that, because they have their slate of legislation ready to go, and then they have a short time frame in which to work. So I really do think from the academic side, the more data we can provide state policymakers on like what has been the impact in telehealth on your populations, what has been the sort of the benefits and any challenges with out-of-state providers, I think that's key to provide them now and going into the fall if you really want to sort of get, if you need a legislative solution at the state level going into next year.
And can I add a couple points? One is this concept about the middle ground, and there may be opportunities for, I call it toggle on, toggle off. You know, when we were looking through the different regulatory flexibilities across the states, there were states, you know, like Florida, North Carolina, who've used these PHEs before related to floods and hurricanes, but, you know, it's never been used in an infectious disease way and definitely not in a nationwide way. But states, you know, these states that have done this before and used these emergency authorities on the Medicaid side, you know, talked about having like a plan B, you know, a managed care plan contract addendum that's kind of ready to go in the case of another infectious disease pandemic from based on lessons learned. So there definitely is a middle ground. It's not necessarily all, you know, expire, all, you know, adopt. There could be further testing, and then there could be toggle on, toggle off. And the other point is, you know, the assessment framework and decision-making framework that we developed, HMA and Manat, you know, hopefully can be a tool to think through some of these, because these are really complicated questions, really complicated flexibilities. While impact data is critical, I just, you know, there's also some that maybe, you know, don't ignore the obvious. Is, you know, there were some that, you know, I mentioned, like, I don't know if every state did this, but a lot of states did have, you know, pharmacy scope of practice flexibilities that allowed pharmacy technicians and pharmacists to administer, you know, COVID tests and vaccines, and states have started to adopt these because they just make sense. They're community centered, they drive and advance health equity. So just don't ignore the obvious and learn from other states. If, you know, there seem to be best practices across, you know, 48 states, maybe it's a best practice in the 2 others, you know, so just not to ignore the obvious.
Thanks. And let me turn to Lisa to ask a slightly different angle on the question. You run an organization, you run a small organization that directly serves consumers. From your perspective, from an operational standpoint, like what keeps you up at night with regard to decisions about, you know, these flexibilities, whether they'll be permanent, whether they'll be unwound, whether there will be some kind of testing period in the middle?
Well, I think obviously we hope that they continue. I think what keeps me up at night is really just the ever-changing needs of the consumers that we're serving, and it seems to never be a dull moment. I mean, I think you know, there's a lot of focus, you know, in health plan contracts to work with community-based organizations, and a recognition, I think, that, you know, of the work that we are doing to provide those wraparound services that that maybe the health plans don't provide. So, you know, really trying to make sure that we can work with them and look at LTSS as much broader than it is, than what maybe traditionally health plans think of or healthcare thinks of. So, you know, and how, you know, one of the issues we have in California, obviously, you've all heard of our fires, right? And so we've got tons of fires, but what happens to the person who has an oxygen concentrator where power was shut off to try to avoid a fire? How do they sustain themselves if they don't have electricity and they can't get oxygen? So, you know, when I talk about emergency preparedness, I'm talking about really, you know, how do we help people sustain and thrive in another emergency? When we have to relocate, and we've had to relocate consumers because they were in fire areas that were being evacuated. So, you know, we've got to get them transportation, and that could mean that it might be gurney transportation, it might be power chair transportation, that can take their oxygen concentrators. That, you know, what about, you know, people that on even medications that have to be refrigerated? These kinds of things are becoming more and more real and more frequent, you know, for every fire season. So you know, those things keep me up at night. How do I possibly, and there needs to be some recognition, these things we have to deal with. I'm so glad, Stephanie, you were talking about the states that that, you know, the hurricanes, and I asked myself, how are they surviving? How are the folks that are having these, you know, people with disabilities and older adults dealing with this? You know, I'd love to, you know, hear how they're doing and what are some lessons learned from them, because I feel sometimes chasing our tails and trying to figure out, you know, how can I fund a backup battery for this person? You know, get them so that they can sustain themselves and thrive throughout the next emergency.
Thank you so much, Lisa. And I think there could be a lot more to talk about there, but I am going to leave this panel right there at that individual level, person-centered perspective, because it might come down to a battery or an oxygen tank or you know, the ability of a caregiver to come into the home or, you know, access broadband. So, so thank you for bringing us that perspective. Thanks to all of you on this really amazing panel for bringing all of your perspectives. I apologize that we didn't have more time for Q&A, but hopefully we can have you all back. I want to thank again the SCAN Foundation for their support. Thanks to our audience for joining us today. Please do share your feedback through the evaluation. We are a continuous quality improvement organization, so we try to really take that into account. And again, I want to thank Jonathan Gonzalez-Smith, Rob Saunders, Hammy Torson, Lisa Hayes, Jennifer Podolka, and Stephanie Anthony for your amazing work and thought leadership and research and analysis, and for bringing all of this work forward. You can check out a recording. Anyone can check out a recording on our website, allhealthpolicy.org, following the webinar. And finally, stay tuned for an announcement about the Alliance's next 3-part series on the future of Medicare. Thank you all so much. Have a great afternoon, everybody, and much appreciated.